So there is a real reflection. We really need to think thin soft tissue, type of bone, level of the implant, height of the eye physio. This is, you have to play with all this. How can you do that when you're a young implantologist? Very difficult. And imagine that when we are doing the guide, setting the guide, we will take in our brain all those parameters to give you the possibility to place the implant depending on the height of the soft tissue and depending on the quality of the bone. It means that we replace the knowledge of the dentist by giving the right possibility to think of all those parameters in order to place the implant. So it's not only a guide to put the implant tridimensionally. It takes in consideration the biology, the type of bone, and the biotype. Okay? So for sure, more you go in this kind of type of bone, type of soft tissue, more you will be in a choice of how deep will be your implant and which kind of eye physio you will choose. Very, very, very important. In order to have this kind of healing you're waiting for. So if you think about the quality of bone. This is a paper published by Wang and co-workers, and I find that, please take a picture of that, because it's very clever to disturb the classification we all know, type 1, 2, 3, 4. There is something else. We need to know the difference between the thickness of the cortical bone and the cancellous bone. This is also a classification. It's not soft and hard bone. There is something between. You have a very hard cortical bone with no cancellous bone. You have no cortical bone with a very hard cancellous bone. So all that is different. I mean, that's why they moved from 4 categories to 9 categories of bone. And this makes sense. Okay? So let's take the worst one, the best one, and the worst one. The best one is the A1. We have the kind of implant we need to use. You see that it's an implant without a large threads, and you have a protocol to drill for this kind of bone. And then the type C3, which is the worst one, no cortical, no cancellous, the worst case is this one. It's like in the 17, 27 in the upper jaw. So this is the protocol, and this is the kind of implant with the large threads in order to be safe. So how can we combine this kind of implant with the kind of bone and the kind of eye physio abutment in order to have the best implant stability and the best soft tissue? You understand me? It's a kind of philosophy. We need today to set it. And no single implant brand have this kind of philosophy. None. None of the brands today have the possibility to think of how we deal with the bone, any kind of bone, and how we deal with any kind of soft tissue, and how, thanks to the kind of implant and the kind of abutment like the eye physio, we can really set the level of the implant and the level of the eye physio in order to create a better soft tissue length or height, even if we have a very thin biotype. But this is something we need to understand. And if you do not understand it, please focus on that. And today, the only way to focus on that and to play with that is to have the right components. And in my opinion, and that's why I start to use this kind of brand, is because I find myself in the both way. Regarding the bone, regarding the soft tissue, I'm happy to have this possibility to play with both. And that's why we have this kind of results. All my cases are very, very stable. Some of them present some problems. And this is the statistics I will show you on the paper we just published. And most of the time, it's because I didn't evaluate the situation in the right way. I didn't read the quality of bone and the quality of soft tissue, and I do not put the implant in the right position, and I do not use the right eye physio, and I always find my mistake. That's why it's very, very interesting to have a kind of a workshop to see how to deal with all those things in different situations, especially on dead animal models or whatever. So you can see this kind of very interesting healing. And this is the paper we published, the very, very important. It's the biggest clinical study on coded abutments to these days. 103 patients with 1 year follow-up, and we will publish the 3-year follow-up in a few weeks. So this is the paper. I will ask you to have a look on it. And what we study 3 things: how the implant positioning is, how the eye physio plays the role in order to have the final restoration, do not compress in the soft tissue. It means that all the workflow was perfect, and also the contact points. If we want to use the eye physio as a scan body, we need to know if this eye physio is really interesting to use as a digital tool. Okay? Anyhow, it was interesting to understand what happened in the real life, in a clinical studies. An interesting aspect also of this abutment is that this zirconia nitride, having a zirconia oxide coating on the top, is not only a simple abutment. It's an abutment with real biocompatibility capacities, the real ones. When we remove the eye physio, most of the time we remove some of the soft tissue weight. It means that we don't have a healing, we have a sealing between this abutment and the tissues. The first cases I had, when I see this kind of very red tissue, most of the time when I remove the eye physio, it starts to bleed. I said, I have an inflammation. This is the first reaction I had. I don't like, because I was used to see this very beautiful white keratinized tissue inside. But this is something where the bacteria will jump on it and go straight to the bone. We have a healing, we don't have a sealing. I'm interested in a sealing. I need to have a tissue totally adherent to the abutment in order to stop the bacteria, biologically stop the bacteria. Very, very important. And then, when we remove this abutment, we for sure destroy the sealing, and we have to use a zirconia polished, not glazed, as Dr. Fan showed this morning. We can glaze this part and polish this part. By polishing the zirconia, we will have a zirconia oxide on the top, and this zirconia oxide is apparently the same as the zirconia oxide on the iphysio. We would love to never remove the iphysio. It would be the best to have a piece of iphysio where you can put the provisional on it and then put the final restoration on it in order to have one abutment one time. We never remove it. You have this healing done immediately on it. So this is some papers published on this one abutment on time, showing that when you remove the abutment, you put the scan body, you remove the scan body, you put the final restoration. In all those back and forth, you contaminate inside the soft tissue, and for sure you will never have a sealing, you have a healing. And the healing is totally exposed. It's just your patient, if he do not brush well, you will have bacteria inside the sulcus and having the problems you saw this morning. So this was published very interestingly with this ROS, radical oxygen species, I discussed this morning, on soft tissue, published by a friend, Ethan, and also discussed on this paper, very interesting paper we published in the 2020 in a consensus conference in Napoli with Giovanni Zucchelli, with Rasperini, with Gilberto Sammartino, myself, and a lot of very interesting perio-implanto guys who really want to know what happened in this soft tissue around implant comparing to tooth. And this is why we publish a lot of paper on that, and I just make a reminder of what we discussed this morning. Exactly what happened inside the bone happened like half on the soft tissue with a very well manufactured abutment. So this is a paper I showed you this morning on zirconia, just to tell you that what happened between the zirconia oxide and the titanium oxide and the zirconia nitrate is quite the same, depending on we are on hard or soft tissue. So this is very quickly some cases. A molar where you need to remove it. I will show you some clinical cases in order to show you different kind of biotypes and different kind of clinical decisions using implants, either Nitractis or iBone, together with those iphysio abutments. So we always put these implants, the iphysio abutment, and we try to cover, if we use artificial bone, we try to cover that with a platelet-rich fibrin, the PLF. Okay, this is how it looks. We decided to put the implant in the distal root because the septum was not enough wide in order to enlarge it. This is another case, and this is how it looks inside the different cases, single crown or multiple edentalism in the posterior area. This is a case where we remove the 3 roots and we have the possibility to enlarge the septum using the Versa burrs. Or instead of drilling, those burrs can compress the bone. So at the time we place the implant, we will fill up the spaces with artificial bone. And if you can please follow the sutures, it's very important to have a real, it need to be tight. You see, I go 2 times and in the middle, in order for me, when I tighten the sutures, I have all the soft tissue wall coming on the eye physio. It's very important to have this sealing, or talking about sealing, the tissue need to be totally safe on the surface. Like when you place an implant in the alveolar, when a part of the implant is not on the bone, you try to put some artificial bone and membrane into to isolate it. Here you don't have any other possibility than suturing in the best way. Okay? So this is also another case, but not a video, where we place the implant. This is the eye bone implant. You already have it here or not, the eye bone?
No.
Not yet. So here we will put some artificial bone and PRF. Here excuse me, just a minute, very interesting. Here I had the cyst was on the palatal root. Excuse me, I'm in front of you, sorry for that. In the palatal root, so what I did is that I put the PRF in the alveolar before to fill it with artificial bone, in order to isolate if there is any infection still in the palatal wall, bone or whatever, just to isolate it from the artificial bone. And then always using the PRF before to suture on this. And as you saw in the beginning, my abutment is really on the bone. And this is very, very beautiful. These are printed models where you can see here the inside after we remove exactly the shape of the eye physio before to finalize the crown, which is done always for zirconia. You have this kind of beautiful views on the work of the lab technician. So you can see here that we are on the top of the bone, and we are not absolutely not taking any space, and the body will remove enough bone, will resorb enough bone to make this very thin layer to be protected against something which is highly biocompatible because it's with zirconia oxide. So now one of the most important things is that this abutment will play the role of scan body. We do not remove it. So this is something published many times just to see that this the way we remove and we replace the abutment is really a source of problems. And the other thing is that when we remove the abutment and we put the skull body, we always have a shrinkage of the soft tissue. When it shrinks, digitally we cannot do anything because the digital scan will take the final positioning of the soft tissue. And the lab technician cannot play like when you are on plaster. He can remove some of the plaster and to make the emergence profile as needed. It is not the case. So what is interesting is that the fact that we do not remove this healing abutment give us the possibility to have in the library the copy of this abutment being the base of the crown. And this is how it looks. How we proceed. We will remove the short screw and put the long screw in order to scan. But this short screw will give the possibility to have an internal piece for the provisional without being cemented. Then the job of the lab technician started, where he will match the virtual iPhysio with the final iOS, and start to work by defining here the limits using this small arrows. He will define the limit between the internal part of the iPhysio and the external part, which will be glazed, not polished. So this is the final restoration. And just to tell you that we are working since many years on the way to select the abutment and the crown using artificial intelligence. And this is a paper I published with Henriette Lerner from Germany to show in a very large number of implants, 106 supported monolithic zirconia crown, which is a very high number of crowns, how by using artificial intelligence we succeeded to have a really interesting outcome for the final crowns. So you can see here the base is exactly the shape of the iPhysio. So when we remove the iPhysio and we put the crown, there is any kind of compression of the tissue because it's exactly the same. It's really taken from the library. But this is how it looks and how we have the final restoration, really stable, because the upper part of the keratinized tissue is not under pressure. The pressure is down. Down you can press whatever you want laterally. Up, no. You press, you can take a photo in the beginning, but with time, this tissue will go and reach the lower part. And this brought me to the last part, which is this emergence angle. The emergence angle is the difference between the diameter of the implant and the outer diameter of the crown. That's why this kind of cases, we had the gingiva in the beginning here. And with time, everything goes down with this recession because of this angulation. And this angulation is too aggressive. That's why we have this kind of recession with time. So now when you have a very thick biotype, no issues. Do whatever you want. Really. Whatever is the convex, concave, whatever you want. But the problem is that in the front area, we never have that. It's very rare to have a very thick biotype like this one. We always have that, a very thin. And I'm coming also to your case. The case was very tricky because, you know, the first slide you show where you have this line and you have what you hope to reach after your surgery. This line, it means that your biotype is very thin. And to have a better biotype, you need to graft, it's very important. But when you extract the tooth and you know that you have a thin biotype, if you react during the first extraction and the first implant positioning by grafting the bone and using this kind of abutment, you push in the right part, you push down and you have already a base. And even if you need to have a better contour, you just need to do a very small gingival graft without like the Tarno style where you just open and you put a graft down in order to have a better contour. You're not in the way like you did to really take your blade and you open, and you know it's very important to solve the problem during the implant placement when it comes to a thin biotype like this one. So never push here, never, never ever. And this is what you do when you use this kind of shape, convex and concave. You need to push down. If you do that, you have a recession, with no doubt. If you use a pushing technique inside, this is the only way to avoid the recession. And why? Because you divide this angulation here, which is very aggressive, you divide it by using a double S shape or a U shape, which is the shape of the iphyseal. So this is the part, the green part, which will push immediately on the top of the crest. And this is what will give you a stability in time, by dividing this angle in two parts. So this is how it looks. With the concave shape, this is how is the crest, no, the implant, the top of the implant, the crest, and the different part of the soft tissue. You can see that for this kind of shape, you have a lot of tissue non-supported. Very, very, very important. You have a lot of tissue not supported. And this tissue is, unfortunately, 80% of water. 80%. But even if you don't have any problem, you just get old, you lose water from your body. And you have less component to be supported here. So what is interesting is when you decrease this part, you decrease by supporting the tissue with this part, which is the shape of the iphyseal, you have less problems, and you decrease the angulation between the implant immersions and the outer part of the crown. According to this author, when you are up to 32 degrees, you have a recession. Always have a recession. Very interesting. That's why this kind of a double S will decrease this angulation between the outer part, which is not the case when you have a V shape or a convex and concave shape on your crown. Okay? So this is the difference. The real difference in the angulation is that you push the tissue at the beginning with the iphyseal, and then you decrease this angulation between the outer part of the crown and the outer part of the implant. So, my conclusion will be combining digital guided implant placement and the optimal emergence profile design leading to a sealing, not a healing. I don't need to have a healing because my healing is very weak, and any kind of bacteria accumulation will lead to a resorption of my bone. So I don't want a healing, I want a sealing. Okay? Let's see 2-3 last cases to finish this session. A patient come in with a problem on the tooth 11, a bone resorption at the end. What I did as a perio is a graft, half keratinized, half non-keratinized, and then place immediately the iphyseal abutment and the provisional. You have to see that there is no conflict between my provisional crown and my very, very sensitive tissue here, graft, because I'm in on the top of the graft. I do not touch the graft with my resin, my provisional, and I do not use any cement. I click it, and you can see that here, that this gingiva is very quickly very healthy because there is no problem of cementing. You can see here on the distal part, you can see the epithelium here, and I don't have any conflict between my provisional and the soft tissue. So when I remove the provisional, some of you will probably see that this is my soft tissue coming and sticking on the epithelium. This is a very, very beautiful view on how soft tissue like this surface. And it's a real sealing of the soft tissue, even on the top of the epithelium. So this is how it looks when I remove the epithelium. Very healthy thing, and when I place the final restoration with a very, very healthy soft tissue and with a very healthy grafting tissue here, as I had to solve this recession problem from the beginning. This is a case also where the patient came with a high mobility of his 221, and with the kind of infection here, I probe in the distal part and I go until the apex of the tooth. I remove the tooth. I place my implant in the best positioning. I didn't need any grafting because the implant was perfectly set with what remained from on the apex of the bone. You have this kind of testing products to see which kind of epithelium you need to use. Normally you need to have this line visible in order to have a good scanning procedure. But even if you don't have it, now we have some, this is what you discussed with my son in Casablanca, that he needs now to really match the process, even if you don't have this black line visible. It's just how your lab technician is skillful. So this is how it looks during the healing. We remove the small screw. In order to place the long one, we scan, and then we put again the short screw, and we reline the natural tooth by placing the abutment, provisional abutment inside. Here we reline it, and you see that we use here an old epithelium in order to see if everything is good, if there's no misfit. For sure it's not the one we will use, because the one we will use is not to be touched. Okay, we take an old one in order to set our provisional and to polish this part as good as we can. So this is the provisional, or the natural tooth used as a provisional. Then the patient asked to do the same with the other central incisor. He don't like the aesthetic. So this is a B shape of the epithelium. This is the healing just before the final restoration placement, and this is the final restoration placement, as you can see, with the final outcome and the final aesthetic. Another case where the soft tissue is perfect, enough soft tissue, because this patient remained with a kind of Maryland bridge in the front, so there was no pressure on the soft tissue. The soft tissue was perfect, but the hard tissue, the bone, was terrible, very thin. So what we decided to do is to do a crest splitting in order to place, and then we enlarge with different kind of osteotomes, like the versalers and the screwed osteotomes. We place here an attractus because it's not possible to place another kind of implant. It's very suitable because there is a microtrace on the upper part of the attractus, and it's not aggressive against this very thin cortical bone. So this is the placement of the implant. We are almost inside the bone. We have a dehiscence on the buccal part. We decided to do not elevate the flap. We just do a kind of a pocket, and we fill up with artificial bone and PRF for sure, and immediately we try to play with the two papillas by having a first incision slightly in the palate. So when we place that and we design the two future papillae here, we suture with the same technique in order to have a sealing, a real sealing of the suture, and we reline our provisional being out of any conflict with the healing. So this is how we ended with the soft tissue, and you can see here when placing the provisional, we just click. Very interesting. Never have any problem with the cementation, because this is really a problem when we did a super good job as a periodontist with graft, and then you come up with this sealing material who can really interrupt the job. Well, this is how it looks at the end, and this is the really what I want you to see is how healthy is the soft tissue around this abutment, because it's really biocompatible. By the surface is really biocompatible. So this is the final restoration. Another case, the posterior area, and I'm showing you this case because it's very, very important to see that even in between the septa, in the alveolar, we will remove bone. Even here, where you will say that I'm removing molars, I need to have as much as possible bone in order to have the maximum of primary stability. I'm always thinking about the soft tissue. I need to remove bone in order to have enough thickness of bone to have a long-lasting result. So this is what we did. We used this piece to remove bone around the implant in order to have our iPhysio seated in the best way inside the alveolar. And you can see here the quality of the bridge, where this part is, as I said, polished, and the other part is glazed. You can see here how perfect is the shape of the future crown. We did the same for the two